Hi, this is Erin Ciascio, student number 3639265 for the fall 2024 semester, and hope you enjoy my video. We are going to be performing a spay on a canine patient today. Our patient's name is Zara, and we will have all of her signalment and everything listed in our practice management system. So Zara is a 1-year-old Hungarian Puli. She's a female, not yet spayed, canine patient. Her birthday is July 4th, 2023, and I'm just reading it off of her patient chart in EasyVet. So in EasyVet, no matter what page you're looking at, whether you're looking at the full clinical record or today's medical record, the full signalment is listed off to the left there, so we can always reference that along with the owner information. And then the spay record will all be here. That just indicates, all findings. We can also create some consent forms here. So we have our surgery consent form, which is a template that we have saved in EasyVet, and then we will change it for the specific client. So we've added in Zara's name, the procedure to be performed, and then we'll go over all of this information with the owner. So your pet will have an intravenous catheter placed before anesthesia. An intravenous catheter provides a direct route to the bloodstream. The use of intravenous fluids during surgery facilitates adequate cardiovascular performance, reduces stress on the heart, assists in maintaining your animal's temperature, hydration, blood pressure, and reduces the time it takes for your animal to fully recover from anesthesia. While undergoing the procedure, your animal will receive anesthetic drugs that prevent pain. Additional pain medications will be provided as needed to control the level of your animal's discomfort, both after surgery and during their recovery time. Underneath are any other concerns or procedures we would like the veterinarian to look at. So I'll ask the owner if there's any specifications, and we will manually add in anything that we would like to suggest that is addressed before the procedure. So in Zara's case, she's due for her yearly exam and vaccines. So we just added that in for the owner and asked if he wanted to do that. Next, we have some additional options. Cold laser therapy. It's just for decreased inflammation, decreased pain, accelerated healing of wounds. So they can accept or decline that. And then we also ask about pre-anesthetic blood work to evaluate major organ functions and to rule out any underlying metabolic disease prior to anesthesia, unless these screens were performed at your pre-surgical consult. So we'll add in something that says already done if they've already decided to do the pre-anesthetic blood work. This patient has not had blood work done, so we would offer that to the owner. The last part of the consent form is I understand that some risks always exist with anesthesia and or surgery, and that I'm encouraged to discuss any concerns I have about these risks with the attending doctor before the procedures are initiated. I understand that during the procedure operations, unseen conditions may be revealed that necessitate additional treatment and or intervention. I hereby authorize the performance of such life-sustaining procedures as are necessary in the veterinarian's professional judgment, and that I will be responsible for all costs associated with these procedures. I've been advised as to the nature of the procedures or operations and the risks involved, including the possibility of death. I realize that no guarantee can be made legally or ethically to me regarding the outcome of any procedure performed. And then we have the owner initial if they decline life-saving measures. So we assume that they will do that. And then we assume that we will do life-saving measures unless they indicate otherwise. Client signature, date, and phone number to contact them. So for Zara this morning, we did have her owner fill out the consent form. So he accepted cold laser, accepted pre-visit blood work, gave his signature and his phone number. So we tend to, maybe I can show it better this way. We tend to keep all of the forms together to make sure that the correct patient is getting the correct procedure. So we have the consent form that we just keep on the clipboard. We have the drug log that is printed for the doctor, and she typically writes the pre-med drugs on here so we can get them prepared. That also has her name and weight there. And then we also have the anesthesia monitoring log. And again, the signalment is repeated up here as well as the procedure to be done. And then we will re-note any pre-anesthetic medications, how they're given, the induction medication, and then anesthesia times, and just kind of other parameters for the procedure. We keep all of this together with the patient name, and we will keep it all in one certain area where we keep all of our surgery forms. So our clipboard with our consent form, drug calculated log, and anesthesia monitoring sheet will all go in this file, along with, it'll be labeled with the patient's name and signalment just to make sure everything stays together. And this is also where we will keep any medications to go home, discharge forms, receipts, just to make sure everything stays together. We also have each kennel labeled, so that will have the patient name and the signalment there, as well as if the cage is dirty or clean, just so we know whether that needs to be cleaned before the next patient. And then anything that belongs to the patient, we've got a comb ready for post-op, and the leash that was brought by the owner, we'll keep that all in one area to make sure we get everything back to the owner. In EasyVet, we have the main patient information and details page, which does the full signalment here. If we go under clinical records, this will show any previous clinical records. Each column of a different color represents a different clinical exam, so we can double click into those, and that full exam is in there, including any assessments or plans by the doctor. And then we also have master problems, and that would list any concerning master problems that we would want to consider before any procedure. So she doesn't have any, she's healthy as far as we know. And then this is our standard of care tab, which has all the due dates. So we'll be suggesting to update those today. We will also request blood work directly into EasyVet under the diagnostic request tab. We use IDEXX, and we have IBLS stations that are automatically integrated with our system. So this isn't Zara, but it would work in a similar way where we would basically order up the diagnostic request. The requisition form isn't existent if we're doing an in-house test, but we can click on the icon and we can navigate to the Vet Connect system, and then it will automatically ask for those tests on our vet lab station. And then when the results are in, they will also automatically update. So for Zara, since we already did the blood work, all of the results will be on the monitor on the vet lab station, but they will also be in EasyVet for our reference. So the doctor will be sure to scan that for any abnormalities before surgery. All right, so for Zara's discharge, we usually do a printed form that we send home to the owner. We also have a template for this in EasyVet, and then we just fill in the specifics, but it'll have her signalment up to the top. I'll go over all of this with the owner. Zara has been spayed today, which involves surgery in a very sensitive area, and therefore she needs care for some time after the event. Unfortunately, dogs do not always understand that they must rest, so we need you to assist in Zara's recovery. When you pick up Zara from our hospital, she may be a little drowsy. This is quite normal following an anesthetic procedure and should subside over the next 12 to 24 hours. Please keep her inside and warm tonight. There may be some bruising, just as in humans, so Zara should not be expected to be completely normal for a few days. Home care is offering small amounts of food and water tonight. Tomorrow morning, she can receive food and water as normal. She should remain calm and rested for approximately 10 to 14 days, which means no running, jumping, bathing, or vigorous activity. It's also important that Zara does not lick her incision, as it can introduce infection and also open the wound. She will need to wear an e-collar for 14 days, and if she's licking when it is removed, it may need to be replaced. Also add in on this part to monitor for the incision site any redness, swelling, excessive heat, or extreme pain after the first few days. Then we'll go over medications. Zara's going home with carprofen for inflammation and gabapentin for pain. Please start both of these medications tonight. And then I'll go over each individual medication, whether it needs to be given once a day, twice a day, how much to give, and then I'll usually show the owner what it looks like just so they're prepared. And then for follow-up, please schedule a courtesy recheck exam in 14 days to ensure her incision is well healed. There are no external sutures to be removed. And then at the bottom are continued complications following the operation. There's very few complications generally following. However, here are some signs to watch out for that may indicate a problem. If you notice any of these signs, please contact us immediately. Dull and listless or white gums, especially after the first 24 hours. Excessive redness or irritation around the suture line. discharge or odor from the incision, vomiting, diarrhea, inappetence, or blood in the stool, urinary incontinence, or no stools for more than 2 days. Some constipation can be normal. And then we'll include that with the invoice as well. So for a jugular blood draw, if I were restraining, I would hold the patient in a sitting position with the back facing me, making sure she's close to my body so she can't wiggle around. I can kind of brace her with my legs. I'm going to put either hand on either side of her head, and then I'm just going to lift her chin up and help the neck be exposed, and then the tech would come into a jugular blood draw. For the cephalic blood draw, similar position. I'm usually securing her chest kind of against my body and making sure that I'm also securing the head so that they can't turn the head in any direction. So I'm kind of wrapping my arm around in kind of a C shape, and then I'll lift whichever leg is needed and twist with my thumb and hold that leg out for a cephalic blood draw. And then for a saphenous blood draw, I'd like the patient standing. I've got one hand under the belly and one hand securing the front and the head to make sure that she can't move her head. And then once the tech is ready, I can slide my hand around, and I will just be placing my hand around the back of the thigh and occluding that vein for the saphenous blood draw. And again, holding the patient against my body to make sure she can't wiggle around. So to properly get a patient out of a kennel, we want to make sure that we're not lunging at them quickly or going into the kennel too quickly. Even if it's a friendly dog, they can usually be a lot more stressed here at the hospital. Got my slip lead ready. I'll make the loop nice and big and hang that down to the door. And give her an opportunity to come out. Good. And then I'm just hanging the loop down so that she naturally walks through it. I want to keep the cage door closed so she can't run out. And then once she's secure with the slip lead, then I can open the door and encourage her to walk out. Good girl. Good girl. Okay, come on. You're so good. So I'm going to be placing it from behind. I want to make sure I'm not putting, this dog is very nice, but that I'm not putting my hand in front of the face at all. So I'm holding it by the edge, making sure that the red part is on the top and that it is a good fit, just kind of based on looking at it, comparing it to her face. So from the back, I'm going to slide the muzzle over the tip of the nose, and I'm just securing it using the sides. And then I'll wrap the muzzle along the back and secure it so that it's tight, but I don't want it to be pressing too much against her face, making sure she has room to lick her lips or open her mouth or pant, and then I'll just secure the clasp. To apply an e-collar, kind of similar to the muzzle, I want to make sure I line up the e-collar and just make sure that it would be a good fit. So I want to make sure that it's going to extend past her nose but isn't so big that it's super burdensome. So ideally I'm applying it from kind of behind. I'm securing her against my body and just encouraging her to put her nose through the hole, which she did, and then I just can't, there we go, and just assist that to slide onto her head. And then this e-collar has just a clasp where you can tighten it, and then just making sure that that's not going to come off. I want it to be firm but not too tight. I should be able to fit some fingers underneath the e-collar, and then another option is I could attach it to her existing collar just to make sure she doesn't pull that off. Okay, come here. Come here. You're being so good. Okay. So I'm going to do a physical exam on Zara, who is here for her spay. We are prior to inducing the sedation, which will then be our pre-med before anesthesia. So I want to start with the nose. I'm going to pull up her lip and check her mucous membrane, which are nice and pink, nice and moist. And checking the capillary refill time is less than 2 seconds. I'm going to take a look at her eyes, which look really good. Take a look in her ears. some matted hair in there. So I'll note that and just make sure the doctor would be okay with us maybe plucking that hair for her while she's in anesthesia. But otherwise the ears look good, no redness or irritation. Lymph nodes feel good. Here, let's back up if you want to lay down. Come on. Okay. Lymph nodes feel good. Just feeling her legs, feeling her belly. I don't feel hernia or anything. Everything feels normal. She's got a unique type of fur, so I want to make sure I physically feel her body condition. And she does feel like a good position. I can feel her hip bones. I can feel the ribs under there, but they're not excessively poking out. So she has a great body condition score. I would say a 5 out of 9. Feel her back legs, which look really good. It's really good. Girl. No. I'm going to start with her heart rate. I'm going to listen to her heart on the left side of her body, kind of behind where her elbow would meet her body. Just listen for her heart rate there. Okay, so in 15 seconds I got 22, so we'll multiply that times 4. So her heart rate is around 88, which is within normal limits. Oh, actually, I'm gonna listen around her chest just to make sure everything sounds normal. So I'm gonna go to the other side. Can hear her heartbeat on that side as well. And just listening for her lung sounds, everything sounds normal. The heartbeat sounds normal. I'd say her respiration rate is around 12 breaths per minute, which is also normal. Everything sounds really good in there. Last thing I'm going to do for her TPR is check her temperature. You can come in. Put some lube on the thermometer. And when I'm doing this by myself, I like to secure them underneath, just with my knee underneath their body. Temperature is 100.7, which is normal. Good girl. And then on her physical examination, Zara's can be rated a PS1. She's very healthy. She's quiet, active, responsive, seems to be in good spirits for her surgery today. Alrighty, I've got Marty here. We're gonna do his physical exam. He's pretty nervous, so I'm just gonna try to keep him close, move slowly, and keep constant contact with him. I'm gonna start with his nose. A little bit of debris, but it looks good. Take a look at his teeth. Eyes have a little bit of discharge. It's a yellowish color, so that's worth noting. feels good, no hernia. He's pretty tense, just because he's nervous, so his stomach is a little bit taut, but otherwise feels good. He's kind of curling his legs, so I'm just gonna do my best to feel everything. And being really good. Just gonna get them a little wrapped, try to make him a little more comfortable. Listen for his heart rate. A little shaky, so it's a little bit difficult to hear the heart rate and respiratory rate, but BD a little bit high, he's just a little bit nervous, and the respiratory rate is normal, right around 10 to 15. So otherwise he looks really good. Okay, Marty was getting a little nervous, so I went ahead and put him back, but he can get an ASA grade of PS1 as well. He is healthy, very good weight. All of his vitals turned out normal, so he's a healthy little kitty. Good job, bud. I feel like I'm just going to like deep. Oh, flash. Good boy. You okay? Good job. I know. My blood pressure's just down this morning. Okay, well, I'm just calling it there, I guess. So, all right. Good job. Good job. I lost it. There you go. Boy. Okay. No. be able to get that. Thank you. It's like, oh, this is a conundrum. Oh. Yeah, this always gets me. So our minimum database for any patients that are going to have a surgical procedure, they need to have a veterinary patient and client relationship. So they need to have been seen by the doctor. If not, they need to have a full exam from the doctor the morning of surgery before we proceed. We also need to have a full history, signalment, and we recommend blood work within 3 months of any surgical procedure. So the owner can decline that, but it's always recommended. And if there are any other abnormalities with the patient, then we would maybe add on additional testing. That could include an echocardiogram with a specialist, abdominal ultrasound if there are any concerns there, or we need to make sure we're ruling out any other issues, or x-rays. So these are all things that are offered on a case-by-case basis, but our minimum would be the exam, history, and blood work. So ideally with our pre-anesthetic and anesthetic protocol, we want to achieve reduced pain, increased safety for the team and for the pet, but we want to have them as minimally anesthetized as possible, just for ease of getting them out of their anesthesia as well as for their safety as well. So for our pre-anesthetic protocol, we generally use a combination of Domitor and butorphanol for dogs, every once in a while hydro, and then for cats we usually do Domitor, butorphanol, and ketamine. We use a drug calculator to present to the doctor. She just kind of has preset protocols that she likes to use. So we just have a spreadsheet here. We enter in the weight of the patient, and it'll automatically populate all the recommended ranges for dosing for the pets. And then the doctor will use that to influence her decision for a pre-anesthetic amount as well as a anesthesia amount. And then she'll relay that to us, and we'll get all those ready. And then for pre-induction, we'll just monitor the patient, let the doctor know if they need a little bit more of the anesthesia, just so that we can make sure we place a catheter and intubate fully. And then at that point, we're adding in the propofol to start the anesthesia. And then we're just monitoring, letting the doctor know if they need more, if they're a little bit too deep. So for the controlled drug log for Zara, we're just going to be using our anesthetic monitoring sheet to confirm the total amount of the controlled drug hydromorphone, and then we're going to log it in our controlled drug log. So on our anesthetic monitoring sheet, our pre-anesthetic of hydro was 0.5 milliliters, and then we marked that we gave an additional 0.25 milliliters during the surgery. So the total hydro that was given is 0.75 milliliters. So in our controlled drug log, we have the name of the drug, the container size, the strength, and the form. So we're just going to fill in the date, the patient name, species, the amount used, which we decided is 0.75, and then we want to subtract the amount used from the balance. So 11.80 minus 0.75 would be 11.05 milliliters, and then I'm just going to add my initials. So the first part of our anesthetic setup are the endotracheal tubes. We have a combination of silicone and PVC Murphy endotracheal tubes, and then we just use a rubber tie to secure them. So we just select the correct size based on the size of the patient. We also have a couple different sizes of anesthetic masks that we can attach to the breathing tube in order to deliver oxygen directly to the patient if they're not intubated. So it would just attach on the end here and go directly over the snout. We have covers if we want to make sure that there isn't any gas escaping into the room. And for our compressed gas supply, we have oxygen in a size H tank. We also have a tank pressure gauge, a line flow meter, and also a pressure reducing gauge here. So that all attaches to this green tube. and that will connect with our rebreathing system to deliver oxygen to the system. Our main breathing circuit that we used is a rebreathing circuit. So when the oxygen enters, again, from the green tubing behind our surgery cart, it goes directly to our oxygen flow meter. This can be adjusted to change the amount of oxygen that we're delivering into the system via this green knob. We also have a button here, and this fills the system with the oxygen. So when we push this, you can hear the oxygen flowing through the system, and it will fill our rebreathing bag. Next, we have our anesthetic vaporizer. We use isoflurane mainly, and the actual oxygen will go from the flow meter, and then it will flow into the import, and then it'll get mixed with the isoflurane gas, and then it will go to the outlet port here, and we will just turn the knob at the top in order to adjust the amount of isoflurane depending on the size of the patient and how deep we want them anesthetized. Then the oxygen, once mixed with the isoflurane, will go up into our inlet valve. So this will be partially the anesthetic gas, and we'll also be mixing with the fresh gas supply just from some tubing behind. So we have our inlet port here. It will go to the reservoir bag. The reservoir bag is a good place. It is a flexible storage for any of the gases that we want to deliver to the patient. So we can monitor respirations using movements in the reservoir bag. We can bag the patient. So if we push on the reservoir bag, it will deliver a lot more of the gases into the patient, just kind of help them along. And then we have some different sizes of bags, which depending on the size of the patient, the size of their lungs, we would adjust the size of the reservoir bag. So when the patient is breathing in, the gas will go into the inhalation valve, and then it will flow into the breathing tube and to the patient, to either the mouthpiece or to the endotracheal tube. And then the patient will breathe out, and it will go back through the breathing tube. We have corrugated F circuit breathing tubes. So when the patient breathes out, the air will go to the Y piece, and it will go into the exhalation valve this direction. And then the gas will exit through the adjustable pressure limiting valve, or the exhaust valve up here. We have our APL occlusion button here. So if we push on this button, that will close the system and not allow any of the gas to escape. This can help test for leaks. And then we have our pop-off valve at the top in case the pressure is growing too great. This will open automatically in order to relieve any pressure that would go to the patient normally. And then after that, it will go to our exhale tube in the back. We have our pressure manometer back here as well. So this does tell us how much pressure is in the system. We want to make sure we're monitoring that when we're doing leak tests or anything like that. We don't want the pressure to exceed 20. So we'll keep an eye on that. The air will go out, and some of the air, since this is a rebreathing system, will go back through our CO2 absorber. So we just have a canister in here, and it absorbs CO2 that the patient's breathing out. The beads in here will change color if they need to be swapped out, so if they're not effectively absorbing the carbon dioxide. And then after it goes through this absorber, some of this gas will go back into the breathing system to be used again. Our scavenging system is just a passive system that goes to the wall vent. So again, it goes through this tube in the back. It goes behind our anesthesia cart, and it goes just out into the outside world. We also have the option of using a non-rebreathing system for our small patients. So patients that are under 7 kilograms, we want to do this. This doesn't have any unidirectional valves or a CO2 absorber, just keeps pressure down for the smaller patients, but it has similar components. So we have our breathing tube, and the air will come in here, it will go to the patient, and then the patient will breathe out through this tube. It does have its own bag with an approximate manometer here and an APL button as well, just to temporarily close the system. And then after the patient breathes out is passive, just with a charcoal canister. So if needed, we have the option to use this. To perform a leak test, I want to make sure I have oxygen in the system. So I'm going to add some oxygen into the reservoir bag, and I'm going to hold the patient end of the tubing. I'm going to use the occlusion button just to prevent any gases from escaping. And then I'm going to put some pressure on the reservoir bag and make sure that I don't hear any air escaping or see the manometer go down in pressure. So it's pretty much holding right around 20, which is good. I want to hold it for at least 10 seconds to make sure that that pressure doesn't go down. And then I can go ahead and release. And so that is a good pressure test on the system. Okay, so to monitor a patient, we've got one device that has a lot of different monitoring systems on it. So we have our pulse oximeter that helps to measure the saturation or the oxygen saturation of hemoglobin. So this just has an electrode that goes, it can go on the tongue, it can go on the ear, it can go on the vulva. I'm hoping to put it on her tongue. Please, madam. Maybe ear too. Oh yeah, or it can just go on the lip. True. We've got the blood pressure monitor, and that just goes to a cuff. We can put that on a forelimb or a hind limb. Forelimb. It's supposed to be here. I want to make sure I secure it tightly to the forelimb, and then if we hold down the blood pressure button on the machine, it will automatically inflate the cuff and measure the blood pressure. And then we have our ECG that will help monitor and display the heart rhythm. It'll also kind of help with the heart rate. So it has 3 electrodes. The white electrode is going to go on the right arm proximal to the elbow. It just attaches to the skin. The black electrode goes on the left arm proximal to the elbow. And the red goes on the hind limb. I'm going to do the left limb proximal to the stifle. And that monitor also has the temperature probe attached to it. So it just has a probe that you can insert rectally or via the esophagus. Put it in the esophagus. I'll put it in the rectum for now, but we might end up moving that. Oh, duh. Yeah. Just add some alcohol to help with the electrodes. And then we just want to make sure everything is reading well on the screen. Perform a leak test on an endotracheal tube. They always start uninflated. So I just want to use my syringe, add some air in, and this is a good way to also check when the cuff is totally inflated. So the indicator kind of is like a soft grape is what my preceptor tells me. And then I just want to look at the cuff and make sure that it is inflating evenly and properly. And then if I want to check the inflation, make sure it's not losing air, I can either watch it over time, make sure it's not getting smaller, or I can submerge it in water. After a few seconds under the water, I'm not seeing any bubbles or anything. So this should be good to use on a patient. Go ahead and remove the air. Make sure it deflates normally too. So we've got the respiratory monitor hooked up between the endotracheal tube and the breathing tube. And the way it works, just when air moves through it, it makes a sound to indicate breathing. So it just kind of helps us monitor her respirations throughout surgery. Okay, so for the esophageal stethoscope, I want to measure it from his mouth and ideally to the 5th rib. And that way I just have a good idea of where it will be sticking out. So this will be just long enough for him. got some sterile lube that I'm going to apply to the tip. Fifth rib or base of the heart. Anywhere in there is great. Kind of a Jackie opening up for me. Just gonna use the laryngoscope. Red. That the esophagus is like dorsal to the
going.
Because I see like a giant. Oh, I see it. I see
It's
it.
very
It's far
easy
up.
when you have it placed.
Yeah.
In the right area.
So I'm just gonna pass it into where I measured it. Attach the stethoscope firmly. Make sure I can hear heartbeat. Perfect. So I can hear the heartbeat. I know that's placed correctly, so I can monitor the heart patterns with that. And then for gastric intubation, we would just use a gastric tube, and there are some markings along the side that I can use to measure. I want to place it the same, put lube on the end and pass it, but I just want to measure it all the way back to the stomach. So then I would place it the same, insert it into the stomach, and then ideally secure it just to make sure that they're not going to bite down or swallow it. This is Jackie. This is my preceptor.
Hi.
She's been in and out of my videos, so she's helping and just kind of monitoring me. So now we can prep. So I'm going to place a cephalic catheter. I shaved a little window on that vein, and then I'm going to clean the area. We've got Chlorhex scrub and some isopropyl alcohol. So I'm just going to make sure I give the area a good clean. Alternating between the two. About 3 times I'm gonna do it. Okay, so with the catheter, I just want to make sure each piece is able to be adjusted before I place it. The catheter should slide in fairly easily once I get a flash. Add on the cap while I secure it. Actually, I might go back with the short one like you did. And then I want to secure the catheter using a couple different pieces of tape. We've got some slits cut in them so they can be seated around the catheter. And make sure to wrap snugly around the leg. After the first piece of tape, I'm going to add my port in. Which should twist into place, so I want to make sure that's snug. And then I'll add the other following pieces of tape to make sure it's secure. Over the port, right? And the last piece of tape, I'm going to do kind of an X pattern just to make sure that the port is nice and secure. Alrighty, I want to flush to make sure that I've got a good line in the vein. And Jackie's gonna feel up further up the leg just to make sure she can feel this flush go through.
We're good.
Okay, so now we're gonna start with our propofol.
Oh, lovely.
Okay. Oh, buy a dookie. I just got here. Hopefully. It's okay if we just stay sideways.
Go the direction the pain's going.
Yeah, just go with it. Oh, come on. That is something special, Duke. Oh yeah. Yeah. Royal Canin does not agree.
That is very correct. Backward catheters, I like to put vet wrap just because it's more likely to get pulled out when
Yeah.
you're moving them.
Okay, so just for, yes, I did the extra last video, wrap the catheter, so that'll be perfect. And you like cut a hole in it, right?
Yeah.
Perfect. Okay, that.
There's a pair out too.
Thank you. This way.
Didn't get a flush out.
Oh,
I don't know if they wanted to see it.
yes. Good call. Thank you. Okay, so I'm just going to give her vaccines. She has some vaccines due, so I'm going to give those subcutaneously. So rabies, we're going to do in her right shoulder. Make a tent out of the skin, poke into the center of the tent, pull back to make sure that there isn't any blood flash, and then plunge the vaccine. It's temporalepto. normally give on the left side, but since she's here, I'm just going to give it in the right hip, and I'll just make sure I note that in the record. And then we'll give the reversal IM. So I'm going to do in the back of her thigh, back muscle. We want to make sure we go into the belly of the muscle. So I'm just going to pinch her thigh to make sure I've got a good bit of muscle there. And insert directly into the muscle. Pull back, make sure I don't get a flash. And push that reversal. So we're about to use our pre-med. So we're going to do an IV injection, and we have chosen hydrodomator and ketamine for this. So I'm going to ideally inject the pre-med IV into a saphenous vein so we can save the cephalic for her catheter. All right, and just gonna hold off that vein. Jackie's gonna take over holding it off, and then we'll just secure her while she. So we'll just put propofol directly into the catheter. And I want to push it not all at once, fairly slowly. And we'll be monitoring for the depth of the induction just based on vital signs. So we're looking at jaw tone, we're looking at palpebral reflex, because we want to make sure that she is induced enough in order for us to be able to intubate and start anesthesia. Fighting back a little bit. So I'm going to do about another mil slowly and check again. I'd say that's better. So she doesn't have much jaw tone. She's not fighting back much to open her jaw. So that is the sign that we want to look for. So we're going to proceed with intubating. So we've got a couple different endotracheal tubes, just depending on whichever one seems to fit her best. So we can kind of measure. This seems big to me, so we need this one. She's so small. And these have both already been leak tested, just to make sure that the cuff is properly inflating. So Jackie's gonna hold the mouth open for me. Can you get a paper towel just to pull the tongue aside? So I will intubate by putting the cuff end of the tube back and against the soft palate. I'm gonna lightly press against the soft palate to make sure I can go directly into the trachea, and I'm just gonna guide the tube into the trachea. Until it is well seated, and as long as it is placed, we'll secure it. Make sure it's tied tightly, and then we like to secure to just to the mouth there.
Yeah.
Okay, wonderful. I'll go ahead and inflate the cuff. Okay. Go ahead and get her hooked up to our anesthesia machine.
2.
Got her set at 2 isoflurane, and we're just gonna do a leak test. So I'm going to close off the relief valve and just put some pressure into our bag.
Sounds good to me.
And Jackie's listening to make sure that there isn't any air escaping anywhere in this region so that all of this is flush and with the anesthesia machine. And now we will hook her up to our monitoring system. So that would like blow air in their eyes.
Yeah.
Instead of doing lube, I'm like, oh, this is counterproductive.
I'll fix this in a second.
Sorry. Okay, to express a urinary bladder, I'm going to put one hand behind her back, and I'm going to use the other to gently palpate the caudal abdomen until I'm able to feel the bladder. I'm just going to gently put, yeah, if you don't mind. I'm just going to gently apply pressure. So Magic's going to be getting a spay today. She's going to be in dorsal recumbency. So we will start by shaving. For a spay, we want to shave from the xiphoid to the pubis and laterally at the edge of the ribs. Okay, I want to vacuum up all of the excess hair that's around her. Making sure I didn't miss any spots. I think it looks pretty good. So then we can start with our scrub. So I have Chlorohex scrub and isopropyl alcohol that I'm going to use. I'm going to do a target pattern at least 3 times. So I'm going to start in the center and go in a circular pattern, always moving outward, starting with the Chlorohex. And then I'm going to go to the alcohol and do the same thing. This will be my 3rd pass, and the gauze is coming away clean, so this is adequate for her pre-scrub. Now we will transfer her into our operating room, just using this towel as a sling. Oxygen's off. Yeah, and we're gonna try to not disturb the site that I just prepped, and then I'll re-scrub once we're in the surgery room. So when transferring her to the surgery table, we want to make sure that we're not touching her and that we're keeping everything very sterile. Okay, so while we have our patient, we've got our pulse oximeter showing all of our readings. So that, along with our fluid line and our anesthesia machine, is how I'm gonna monitor during his surgery. So we have all of our values to the left, percent ISO, O2 flow, fluid rate, heart rate, pulse, respiration rate, SpO2, blood pressure, temperature, and CRT, capillary refill time, and mucous membranes. So I'm just going to go through all the values that my pulse oximeter is showing me and fill in everything that that gives me. I tend to use the reservoir bag on the anesthesia machine to count the respiration rates. It does say it on the pulse oximeter machine, but I like to just confirm that what I'm seeing is the same. About 8 respiration rate. Just reset the blood pressure cuff. So once that gives me a number, I can mark that. And I will check the capillary refill time and mucous membranes manually. Those are less than 2 seconds, nice and pink. And it says 76 degrees, so I don't believe that. I'm going to manually check the temperature as well. If CPR needs to be performed on a patient, I'll have different techniques depending on the size. If it's a larger or a deep-chested animal, I want to use 2 of my hands and the heel of my palm in order to perform CPR. For a patient that's this small, generally under 10 kilograms, I just want to use my dominant hand. I want to have them in lateral recumbency, and I want to do chest compressions. The pace that I want to do is about 100 to 120 compressions per minute. So it's a fairly quick pace. So I want to be squeezing about 1/2 to 1/3 of the patient's chest, and then I want to let them naturally to refill. So I want to do chest compressions for 2 minutes straight, at least for each round. So I'll begin doing that. The patient, I want to make sure has an open airway if they are able to breathe. And if I'm not able to intubate or I'm by myself, then I just want to do some manual breaths. So about every 30 breaths, I want to manually deliver breaths directly to the mouth of the patient. So I want my mouth to cover the nose and mouth, and I want to give 2 quick breaths. And then continue on. If we were able to intubate or I had someone helping me, we would intubate with a breathing tube, and then we would attach the ambu bag to the breathing tube, and we would deliver oxygen that way. So we would just squeeze the ambu bag in order to deliver that oxygen, and we would continue to do chest compressions while delivering the oxygen. Ideally, we would do about 10 breaths per minute, and we want to aim for 10 milliliters of oxygen per kilogram of body weight. Okay, so to do a surgical scrub, I just want to wash my hands first, make sure that they're clean. And I want to prepare gown. Just pulling on the corners of the outside drape without touching any of the inside contents. And I also want to prep the gloves into that sterile space. Also want to prep my surgical sponge. Start by picking my nails, make sure that there is no debris underneath. And then I'm going to start scrubbing. So starting with my left hand, I'm going to do 10 scrubs at the tips of my fingers. I'm going to start by doing 10 scrubs using the sponge side on the lateral side of my finger. Then I'm going to do 10 scrubs on the top of my finger, 10 scrubs on the bottom, scrubs on the inside. I'm going to repeat that for each of my other 4 fingers. And on the last finger, when I'm doing this lateral side, I'm going to scrub the whole lateral side of my hand 10 times. Next, I'm going to do the top of my hand 10 times in a circular motion. And I'm going to do my palm 10 times in a circular motion. I'm going to do the inside of my thumb 10 times. And then I'll do the remaining sides of my thumb. On the medial side of my thumb, I want to do down the whole medial side of my hand. Then I'm going to split up wrist to forearm into 4 quadrants each side and scrub each side 10 times. Next, I'm going to repeat the process on my right hand. Okay, once I'm done, just discarded my sponge. I want to rinse my hands fingertips first. So putting them through the stream and then moving up my hand, making sure I'm not touching anything, I'm letting excess water drip off of my elbow. I can do that a second time if needed. After drying my hands, I can put on the gown. So I want to lift the gown by the neck. I'm going to step away to let it unfold. And I'm going to gown. Push my hands into the armholes. And I'm going to have an assistant come and tighten. Okay. Okay, so now I want to put on my gloves. I'm going to pick up the right glove with my left hand. I want to hold the cuff of the glove, making sure the thumb is against my thumb, palm to palm, and that the fingers are facing towards me. Then using my left hand around the drape, I'm going to pull it over my hand in the sleeve, and then I'm going to pull down and pull my hand into the glove. I'm going to repeat the process on the left side. Okay, so now I'm sterile. I want to make sure I'm not touching anything, and I want to keep my hands out in the open so they're not coming into contact with anything. Okay, so if I were sterile now, this is what I would do to set up for surgery. I've got my patient in dorsal recumbency. I've got the first layer of my sterile pack already opened. Now that I'm sterile, I want to move slowly, make sure I am not touching anything outside of the sterile field. I will undo my pack. And I want to arrange the instruments just so they're easy to access for the doctor. To drape the patient, I want to start on the side closest to me. I'm going to set the first towel on the side closest to me laterally. I don't want to reach across the sterile field, so as best I can, I want to place the next towel on the other lateral side. Next towel I'm going to place cranially. This is where I will apply the first 2 clamps, ensuring that the clamps are going through the towel and into the patient's skin. And then I'll place the final towel caudally and place the last 2 clamps on the remaining corners. This will leave an open square for the operating site. I'm just going to spread out the instruments just a little bit more to make sure that they're easily accessible by the doctor. And then I will stand by to see how else I can assist.
This down, and then if you want to hand me the spade hook, in just a second, we'll find her other side. Thank you.
So for those types of tools, without a hinge, I just want to hold it with the tip facing up, so it's easier for the doctor to grab.
Okay, I like it. So we'll clamp this side. You can hand me the hemostat. Clamp. That's perfect.
Okay. I'll do 2 of those. Tip down. So I'm handing the hemostats. I want to hand the tip down and make sure it's clamped on the first clamp for her.
Okay, I need to cut this. I'm gonna need my blade and my thumb forceps.
Okay. So for the blade, I want to do the point towards me and the blade away from my hand.
Yes, yes, yes. That would be perfect.
Okay, so I'll just use the hemostat to pick up gauze, and I want to make sure I clamp it. So if I do need to dab any excess blood, I would do that without making sure touching anything else.
Okay. I'm gonna go ahead and dab. Basically there. Nice to see. Thank you. And I'll cut it and we can dab again. Make sure we're.
Yes, I saw it was normal. So to load the blade, I'm just gonna pick it up on the non-sharp edge, and then I just want to slide it into place, and it is ready. During surgery, it is important for the technician to make sure that we are ensuring sterility while supporting the surgeon. So we want to make sure that we are arranging all of the instruments in a way that makes it easy for them to access, and make sure that we count them so that we don't lose anything or leave anything in a patient. So if something is dropped, we just need to leave it on the floor. Hopefully we can continue without it. If not, we would want to do a quick sterilization if that is a necessary tool. If a glove becomes perforated or contaminated, we want to re-glove, ideally with an assisted glove manner. So we would need help from an assisting technician, but they would just help us get that glove back on, and then ideally not contaminating the gown. So we would just pull the gown up past the hands and re-glove. Some other responsibilities during surgery are to make sure that any exposed tissues are staying moist and are being cared for by being blotted if needed. We also just generally need to make sure we're maintaining homeostasis. The last thing, it's important to make sure that we are not so focused on the task at hand that we aren't taking care of ourselves. So we want to make sure that we're not locking our knees, that we're, kind of putting our weight on different areas of our body. So we don't want to become too exhausted or too painful in any way so that we can no longer do our job.
Okay, cutting. So as I bet this thing just stay in one spot.
Just want it on the tray, or do you want to take it?
The trays on the tray. It's stuck in there.
Yeah, that's not ideal.
Happened a lot more recently.
Oh, really? That's
Yeah,
out?
he kind of gives it to me half, sticking
Oh.
out.
Yeah.
He just doesn't want to get out of the second seal. Okay, we're gonna go and start cutting.
Alright, wanna come out? Or you come out on your own? Better than these. Did you already listen to this, Kat?
No. It, I still have some air bubbles in this. That first time, so let's hit it again.
Okay.
And surgery time was started at 10:44.
Thank you.
43. 10:43.
So the hot dog warmer needs to be cleaned with a Lysol wipe, but everything else I will, no, you're good. Yes, everything else I'll put out, and I wanna spray with Rescue, everything that was used, and then I wanna let all that sit for about 10 minutes. So I've got Rescue. And then all the surgical utensils, I'm going to put in just a dish. I'm gonna soak them in cold water for about 5 minutes, and we just have a little bit of a cleaner that I'm just gonna spray in there with the cold water just to help loose any big debris off of these instruments. How you doing, buddy? Stay there. So after 10 minutes, I can go ahead and wipe everything down. And finally, I want to spray the surface with the Rescue, and again, let it sit for 10 minutes. So after using a syringe, I want to make sure that I'm disposing of it properly. So usually the cap is on the table, so I just want to load it back onto the cap, and then I can secure it, reseat it into the cap just on the outside. I don't want to ever be poking the needle towards myself, holding the cap like this, or pushing it down with my thumb. So once it's seated, I can go ahead and twist it off, and I'll just put it directly into the sharps container. The sharps container is for any needles that are used, as well as any blades for surgery, any suture needles as well. And then we just want to make sure we're not exposing ourselves to the needle or pushing our hand up against it. After the instruments have been soaking, I'm just gonna brush them with a toothbrush just to get any big debris or blood off, making sure that they just visually look clean. And I want to give a rinse and then let them dry just to the side. The endotracheal tube ideally doesn't have any cleaning products on it. They can break down the plastic of the endotracheal tube. So I'm just going to give it a really good rinse, a really good brush inside and out. So I've got a toothbrush for the outside, and then I have brushes for the inside. I just want to make sure I give it a really good scrape and then let that dry as well. To wrap a sterile surgery pack, I've got all my materials laid out. This is a laceration pack, so I'm just gonna stack everything in order of size. So I want smallest on top, and I'm making sure to line up the loops of all of the materials. I'm just gonna insert this through all of, and I'm just gonna stack everything on top, trying to keep everything as compact as possible. Once everything is arranged, I'm going to add a sterilization indicator. So it starts out looking like this. It's kind of a light yellow. And then I want to make sure this is tucked into the very center of the pack, and that color will change to indicate that it has been adequately sterilized all through the pack. Let's just tuck that in there. And then I'll begin with the inside drape, the side closest to me. I'm gonna fold that towards the center and folding back one corner. Then I'm gonna go to the left side and fold that over, folding one corner back. And the right side, making sure all this is nice and taut. And again, folding back one corner. And lastly, the furthest side, wrapping that in, and then I'm going to tuck this underneath. And again, leaving one corner sticking out so that can be pulled without touching all the contents of the pack. And do the same thing with the outside layer. So starting with the side closest to me, fold it up, folding back one corner, left side, folding back a corner, right side, and the furthest side. Tucking that in, so about an inch sticking out. I don't want the lip sticking out too far from the pack, but it needs to be easily accessible. Then we also have steam indicator tape that we will use to secure this pack closed. I'm just with a Sharpie, I'm gonna write the date, my name, and what type of pack it is, so laceration. It's like that when it's done. So to wrap a gown pack, I want to lay out the gown with the open side up just to make sure that the panels line up. And ideally we want as easy access to the open back collar, because that's where we're gonna get into the sleeves. So I want to flip it over so it's on the other side. Just want to make sure everything's lined up well. And before this, I gave it a quick lint roll just to make sure there wasn't any hair or anything from the laundry. So I'll flip it over so it's all straight. And I want to fold the arms forward. And then I want to fold both sides in. Maybe about 3 times. So that they meet in the middle and there's enough space to still access that collar on the back side. Then I want to accordion fold it, keeping that back collar at the top. So I'm going to do my first fold, making sure that that is up and centered as much as possible, like that. And give it an accordion fold. So it's nice and compact. Then I'm going to put my pack drapes out diagonally. I'm going to start with the bottom side, fold it up and fold it back. Corner first. Don't want to forget to add in my sterilization indicator into the center to make sure the sterilization goes all the way to the center of the gown. I'm going to fold up the bottom corner, folding back the corner so it's easy to grab. And then I'll fold over each side, again folding back the corner afterwards. And lastly, folding the last side and tucking it in so that there is a little triangle sticking out. And then I will just repeat that process. And I want to secure it with my steam tape. Make sure there's enough of a corner sticking out to grab. There we go, that's better. And I want to put my initials, the gown, and the date on the tape. Autoclaving works by sterilizing any materials put into it using high pressure steam. So with the pack that I've made, along with any other packs that need sterilization, I will ensure that the autoclave is properly filled with distilled water. It's filled adequately, and I want to close the lid and make sure that it is completely secured. Make sure it's nice and tight. Since it is a high pressure situation, I don't want any of the steam to escape. I'll turn it on. I have the temperature at 273. Switch it to the steam setting, and I'm going to turn that on for about 30 minutes. So the timer on the autoclave is at 0 and it's no longer on. So I want to switch the setting now to exhaust and set the timer again for about 15 minutes. That'll help release all of the pressure that's in there. Okay, so after it has finished with the exhaust, I will turn this to 0, turn this off. And open the door. It is warm, so you just want to be careful. And then we'll just let this air out and cool off. Okay, now that everything's cooled, we can double check. So this tape was not striped before. Now that it's striped, that shows that it is now sterile. And then we'll also double check the tape or the tab on the inside to make sure that everything is sterile. So we have Duke here for suture removal. He had a mass, a rectal mass. And so we are looking at that. Checked in with the owner to make sure he wasn't messing with the area or anything like that. So take a quick look. You can see the suture right up there. And I'm looking for redness, swelling, any oozing, or any other debris, any darkness, any dehiscence, and like that. But this looks really, really good. So I know that it's ready to remove that suture. I'm gonna try to clip right underneath the knot before it goes into the skin, and then just pull out the suture. It's removing really easily, which is a good sign. And after the sutures are removed, I don't see, again, any concerning redness, swelling, anything like that. So he's cleared, he can go back to normal activity, and he doesn't need to wear a cone anymore.